Hello, everyone. This is Dr. G at the Heart of Healthcare with some super bonus info for you, super bonus content, I should say. So I have my friend, Dr. Lauren Templeton here, and we're going to do some myth busting today. She is a hospice medical director in Abilene, Texas, consultant for Weatherbee, and an one on the regulatory committee for NHPCO. So she knows all the stuff. Everyone wants her input when they're in the AAHPM form. So I'm so happy she's here, and we're just going to do some myth busting about hospice because that's what I like to do. So, hi, Lauren.
Hi, thank you for having me. I'm so excited. This is my favorite topic is to bust these myths. It's super fun.
I'm so excited. Well, sorry, we're going to call you Dr. Templeton. So,
Okay,
Dr.
sounds
G
good.
and Dr. Templeton, we're going to bust these hospice myths. We're both uh, passionate hospice medical directors. We're on the Hospice Medical Director Certification Board. So, we're just friends. And I think hopefully one day we'll meet in person, right?
I know, I hope so. And I hope it's in your state. I want to come to California. That sounds, I
Yeah,
think that sounds required. Yeah,
I
absolutely.
I think so too. I was actually in your state over the weekend, so we'll figure both of those out. So
Perfect.
let's jump into our top 10 we have here. Let me get my notes together. Do you want to say anything to our audience before we get into it?
Just that I'm so passionate about hospice care, even from educating hospice staff and talking to the public about this because I believe so much. And so I'm just so grateful for the opportunity to really empower patients to feel comfortable seeking out services that they deserve to have. I mean, we're talking about a difficult time for patients and families, and I want them to feel supported. And I truly think that hospice is supposed to just be a support team in hard times. So I'm excited to taking, a little bit out of the fear out of things.
You just said the whole mission. I like to make hospice less scary and make hospice more friendly for our society. So I'm just grateful to have experts here and bring it right to the people where it belongs. So let's go.
All
Hospice
right.
myth busting 101. Number one. So I'm going to say the main one and then we'll just go into it. So, number one, no hospice referral, no problem. You do not need to order a hospice referral. You can call the hospice yourself. What's up with that? Why do people think that?
Yeah, this is just hospice is a patient-centered benefit. It's your right. We talk about things in terms of Medicare, but obviously private insurance, if you don't have insurance, this is something that patients deserve to receive. And so you literally have enough on your plate dealing with a terminal diagnosis as a patient or a loved one who's caring for someone who has a terminal diagnosis. You can call a hospice and say, look, my doctor said that this is a diagnosis that is scary and maybe that we're talking about our last months of life. And I want to look at what comfort looks like and how supportive care might look like with this disease that I have. Hey, hospice, what do you have to offer me? And it's that simple. I mean, you don't have to, it doesn't have to be anything else than that. I mean, we put enough barriers to ourselves in the healthcare field. Having to have a referral is just not one of them.
Yeah. In my hospice I worked for previously, we would run into that barrier. Sometimes primary care doctors don't even know their patients in the hospital, or maybe they haven't had the end of life conversations with them. I think it's a challenge for some of them to let go of their primary care patients, and that's another thing we can get into. But um, having the conversation is the main thing. So now that you can call yourself, that's it. The other part of that I wanted to add is no one puts you on hospice. Often when I go visit a new patient and their family, I'll ask the family, how did you decide to put your mom or dad on hospice? And they'll say, oh, the doctor put me on it, or they said I have to. And it's like, no, you were, it was recommended, but you elected for it. It's an election of benefits when you meet the eligibility requirements for a terminal illness. And so most of my patients or your patients probably come from hospitalizations, but that's just what it is. So,
Mhm. Yeah,
yeah.
absolutely. It's definitely a choice and it's a right. It's a right to receive this type of care.
Yeah, yeah. And you get hospice physicians like us, hopefully. So
Mhm.
let's go on to number two. You can keep your primary care doctor when you choose hospice care. You don't have to give them up, or you might want to, but that's what we said too. So tell us about that.
Yeah, so part of hospice care is that you have the interdisciplinary group, and you've covered that the doctor, the nurse, the social worker, and that supportive pastoral care support. And so, in addition to that, the patient can choose who they want to be their attending. Now, 100% your choice, and you can choose not to have an attending. And so, some people want to choose their primary care physician, sometimes they want to choose their oncologist. Now, that physician might also say, I don't have expertise in hospice care. I'm your expert PCP, but I'm not your expert hospice doc. And that's okay too. And so at that point, you're always wrapped up in the support of the hospice doctor. Now, the reason I laugh and say you might not want to is just that part of our healthcare industry is driven towards specialists. And so, when we have a major heart condition, we go to a cardiologist. And when we have cancer, we go to our oncologist. And it's okay when you go to hospice and you go to your hospice physician. I'd encourage you to make sure that that hospice physician has experience and maybe even a certification like HMDC. And it's okay to go with them too, because they're hopefully experts in what's going on. You want to surround yourself with a good team. It's hard to lose a PCP that you've been with for a long time, but sometimes they're more like family. And I see them transition you over to the hospice team, not because they want to abandon you, but because you're family. And so they're deferring that doctor role to a hospice doctor. And then they just get to be your PCP and supporter in the background, because to me, I think it's emotionally a little bit easier for them.
Ooh, I love how you said that. I have nothing else to say about that because that is challenging for them to, feel that
Say
family
goodbye.
role. Yeah. Yeah. And so we happily take the baton and they can be your family and it's no failure on their part. You know,
No.
all these, we talked about this in one of the episodes, chronic diseases have a trajectory and decline towards death. It's a part of the circle of life. And so that was so, so well put. Hopefully that liberates people. But the main question about your doctor that you want to follow you, do they do home visits? Because we do. That's our jam, right, Lauren? Yeah.
Yeah,
So
I
what
love him. It,
yeah, and what we do as a team,
it's
just to
just a
let you guys.
blessing to meet people in the home.
Yeah, absolutely. And what we do is if they follow along, we can update them after our interdisciplinary team meeting. I've done that before. I can call them or the nurse can call them. They can even be on call for you. Most of them don't want to get the call at 3 o'clock in the morning though. But that's how it goes. And there are some things TMI, but if there are any doctors listening here, which I believe there will be, there's billing availability for relatedness and unrelatedness. So that's something that you can learn about. So that's it. Number three, I always say this, it may seem inappropriate, but it's not, but hospice is not jail. You can decide to leave hospice at any time. If you're dissatisfied, you can transfer to another hospice agency without losing your benefit time. And if you have second thoughts, you can revoke your benefits and start calling 911 every week if you want. Whatever you want to do, it's not jail. Let's talk about it.
Yeah, I love it. And, we started this with saying hospice is a choice, right? So it's a choice to enter it and it's a choice to leave it of the patient or their representative. And so, yeah, one, if you're not getting great care, like we're talking about having a great hospice doctor leading your team and the nurse is coming to see you and really addressing your needs, you do have the right to transfer hospices. And like you said, you can do it once in a benefit period. without losing those days. But honestly, I think some people's hesitation about hospice is, well, what if it's the wrong choice for me? Well, that is scary, of course. But if you feel like it's right, and then maybe things change, human beings are allowed to change their mind. And so that is a right of the patient on hospice is if you choose, hey, I know they said that I was a candidate for this third line treatment. And at the time I said no. But over the past couple of months, I've been thinking and, maybe meeting with the chaplain and that spiritual support to decide, I think I am ready to attempt that third line treatment. You can choose to revoke the hospice benefit and you go right back into your previous Medicare benefits.
Exactly. And so that's good. There's the info. So we'll move on to the next one. Number 4. If you're able to travel, go. A hospice agency can contract with another hospice agency outside of the service area, and you can continue to be on service.
Yeah, I love it. And this is part of the hospice jail too. You don't have to stay on hospice and you don't have to stay at home, right? We want amazing things. Like we're already dealing with terminal illness and difficult situations. And our goal in hospice is to achieve your goals. And so if that's getting across the country to attend the wedding of your granddaughter, that's our goal too. And so we want to work to facilitate those types of things. And so the hospice may choose to help facilitate a transfer contract if you're going to be there for a long period of time, like we said, the transfer, or contract with them for services there because you're going to be there for a week or two, or maybe it's the right thing to come off of hospice. But the point is that hospice shouldn't be limiting you from good times. It should be facilitating the good times. We have lots of tricks up our sleeve, including contracting with other hospices, even if it's across the country.
Yeah. And then if you happen to go with a national agency, they have branches around and they can do that internally. And also, I wanted to mention on this part, the hospice social worker we talked about a couple weeks ago works with the doctor. And if you need a letter, sometimes the airline wants a letter. And so they may work together to write a letter just describing the case you're in so that you can have equipment that's compatible for travel and things like that. And so that's something that happens too, but it's a case by case situation.
Those are the fun letters to write, right? Like, yes, my prescription is the trip to Hawaii. This sounds phenomenal. Those are the fun documentation things. Yeah.
Right. And that's why I said if you can travel, because obviously if you wait to come on hospice care or wait to put your loved one on hospice care, too late, then you can't really get the full benefit of the time. So hospice, just for review for everyone, the benefit is 6 months and there can be an unlimited amount of benefit periods, but typically you want to benefit from the 6 months that you get. But most people, as we know, wait, just till there's a few days. So anyway, we'll deal with that.
Yeah, I love the idea that we, if you're waiting until this big event to come on hospice until after, imagine what it looks like a little bit different than if you get hospice earlier and you get your pain well controlled and, that swelling tidied up, and then you have them help you facilitate getting that oxygen. That's a concentrator that's, able to be transported across the country. Now you have a support team whose goal is also to be in your corner to get to the big event versus what you're saying, which is some people who wait until the last hours and days. And we didn't get to be your support team for this stuff. And we just love the opportunity to do that. But it takes an earlier referral or a patient calling in for us to have you for a little bit longer in order to get these good stories.
Yeah. And we like those. We call those wins. So good. All right. Well, number 5, we're halfway there. Some patients graduate from hospice care. What?
Yeah.
What is that about? We call that live discharge, people.
Yes, exactly. It's a good thing. And so it's so interesting because many of our patients and families don't think it's a good thing. And the reason that is because we are such a good support team. You don't want to lose that support. But what it means is that when you come on hospice, it's that a physician thinks that you have this illness where it's not unexpected that you might pass away in the next 6 months, not required, like you said, just not unexpected. And that your goal is really to focus on quality of life. And so if after a few months or 6 months or longer, because it's not limited, and this could be a year into things, the doctor says, I think now it's most likely that you're going to live longer than 6 months. That's what we call graduation. It doesn't mean that the disease didn't go away. So a lot of times this might be patients with Alzheimer's disease or COPD or congestive heart failure. It doesn't mean that you don't have the chronic illness that you were talking about. It's that what we're talking about is you're graduating. The physician's opinion is that you're probably going to live a lot longer. And so then the hospice team is required to step out of the picture.
Yeah. And, when we have this close, intense care of someone, which I believe hospice is like intense care, you have all these people come into your house checking on you. It's not waiting for the 2-3 month follow-up and then you go to the hospital in between. No, we are on top of it. We're available 24 hours a day, and we use sometimes stronger medicines to get things optimized, and the patients can feel better if they're not too far gone, like with those diseases you mentioned, heart failure and the COPD. And so we see that. And the nurses, I love to use the term graduate because, the nurses, they don't want to, discharge people or make them feel abandoned, because we do become a family during that time, and probably adds to the anticipatory grief of everything. Sometimes the families are confused or like, wait, what's going on? Or, especially with the dementia, there's a lot of anticipatory grief there. And so they're wondering, what's going on? Like, I've had some people ask borderline inappropriate questions about, how long they're going to be around. And it's like, well, they're still here. They're still, worthy of care. And so that's how it can be. So anyway, let's move on to number 6. Hospice care has limitations, and I'll explain. You can get kicked off hospice. Okay. So let me explain. So the hospice agency, this is very rare, we'll say, can ask you to leave if your home is dangerous. Now, we know you Texans, you guys have your guns and all this stuff. We're not talking about that. Everything's locked up, right? But it's about if the team is able to safely provide care. Now, I don't want anyone to feel ashamed of their home environment. Everyone lives differently. This is extreme cases of things occurring. I actually, on one of my teams, have a patient who lives in a tent on Skid Row. That's their home. And so don't feel any type of judgment as to how your home is presenting. This is about things that are environments that are unsafe for our healthcare team to take care of you. So you want to help them understand that?
I do. And just to reiterate, this is the rarest thing that occurs. It is not very common. It's what we call discharge for cause. And the cause is really, truly something very significant that it impedes the ability of the hospice team to provide care for the patient. And there's so many layers to this. And we work together to try to fix the issue first and foremost. And we try to get you resources. We may even contact community departments to help facilitate fixing the issue, the root cause. But this is truly something above and beyond that impedes the hospice's ability to provide care. This is never a surprise. So if this is happening to a patient, they know about it, or their representative, they know about it. They're trying to fix the issue with you. They're collaborating closely with you. And ultimately, again, super rare. I love how you say that has nothing to do with things like if your home doesn't look like the social media perfect home, because hospice is about meeting patients where they're at and advocating for how they choose or want to live. And it's really about just being a patient supporter. And so if you're living in a tent, then we're coming to see you in the tent, you know, and if that's how you choose, then we're there with you as your support team. But yeah, technically you can get kicked out if you are putting our team's, life at risk on a regular basis, and we can't get this figured out. That is a potential consequence. Yes. Like you said, in Texas, we got to navigate those guns. I mean, those things just happen. But
they're
this
all
is about
locked
being
up.
collaborative. Yeah, there you go.
Yeah. Yeah. And like, I mentioned the guns, I might as well say it. I think on my other podcast I had in 2021, a guest mentioned someone had a gun pulled on them at the person's house. So we're talking about extreme things like
Extreme.
that, violence going on in the home, drug selling, again, we would get our resource expert, the social worker involved. We would try to remedy the situation. Sometimes we have to call APS to get resources and support. Sometimes we provide interventions if it is a cleanliness issue. I've seen those before. We've had the house clean for people, if it was a, kind of hoarding situation where it could be unsafe, things falling, so we help. We love the work that we do. So everything that we find out about or try to intervene on is all for the best interest of the patient and the family. We take care of patients and families. So we have to cover that though.
Yeah.
Because they say we're like the nicest people and we're angels, which, okay, we'll take that, but you still could get kicked out.
Yeah. But we know how to set boundaries. We can still set some boundaries. Yeah.
I love what you said, that accountability and boundaries. You said that. Yeah. So, okay, we're at number 7. Oh my gosh. So high level hospice care happens. So we're talking about GIP. We're talking about continuous care. We're talking about higher levels of hospice care because there are 4 levels. So let's talk about that.
So the vast majority of what hospice is doing is in a home and what we would call the routine home care level. But sometimes, especially because we're dealing with these serious illnesses, patients just need more. And this is what we call the higher levels of care. So general inpatient care, I call it like a hospital hospice. It doesn't necessarily have to be in a hospital. It could be in an inpatient hospice inpatient unit. It could be in a contracted nursing facility. But the point is that it's really, truly intensive care that cannot be provided in the home or at that regular routine home care. So this is what we would think of as a crisis. And the hospice team is literally swarming around the patient and their family or representative to say, how can we fix this crisis? And because we're looking at it as a crisis, it's typically short term. And so this might look like, you have acute shortness of breath where you previously would have said, call 911. But now you're saying something like, I don't want to go to hospitals anymore. And so this is where the hospice might try what they can to fix it in the home. But this just means some intensive intravenous medications, nursing, really truly skilled nursing interventions, the physician, the entirety of the interdisciplinary group swarming around you to support you in this location, higher level of care, whatever that might be. Now, there's a similar higher level of care that occurs in the home that we call continuous home care. And this is the same thing. It's the crisis that we're trying to resolve. And so just like the general inpatient level of care, this is acute symptom management, designed to be short-term, that we're meeting you in the home. Now, continuous is a little bit of a misnomer, because it doesn't mean that hospice is moving in with you to live with you continuously. Okay. Right. That's something to, a general misconception. And they're like, what do you mean you're leaving? I thought you had your suitcase packed to stay with me for the next 7 days. That's not what it's like. Yeah, exactly. And so this is really, again, the crisis that we're trying to get solved, where they are in the home many hours of the day, but they're not moving in with you to take care of you, but they are doing everything they can to work together as a group to get those symptoms and that crisis abated.
Yeah, that's good. And, any good hospice provides all 4 levels of care. You should expect that. And that's something that you can look at, you can ask about. We'll provide the info for hospice care compare, for those kind of things. But that is a part of the Medicare hospice benefit, having all 4 levels of care to manage symptoms. And whoop, there it is. So number 8, okay, this is the real one. So listen up, everybody. Hospice patients are not only prescribed morphine. Guys, we're going to have to bust this one. We need double guns for this one. So comfort medications can come in handy, but you also don't have to stop all your routine medications. So the medications are reviewed for relatedness, necessity. Sometimes we deprescribe, if you're on 20 vitamins, if you're unable to swallow, then why do you really need those? And we also do shared decision making for treating things, infections, UTIs, pneumonias. If you have ascites, your stomach's getting full, you may need to get that drained. Maybe you've been getting that drained every week for 5 months, and now you're going to do that at home with the catheter that they can place in there. So all these things are talked about. You don't just go there and they put you on morphine and that's it. So let's talk about all this. Let's unpack it.
Yeah, I think maybe we should have made that number 1, because that's the most common myth for me and what people are afraid of. And look, I know how to use morphine very well. I know how to use that medication, and it's a wonderful drug when we need it. I mean, it absolutely, but it is just a small part of what we do, and not even for every patient. The first thing that we do is meet you where you're at with what's going on with your disease and what are your goals and how can we achieve palliation. Or palliation to me is just easing of suffering. That's all it is, trying to make this difficult thing better. And so that might look like, yes, deprescribing or stopping some of those medications, which guess what? Some of them aren't even supposed to be taken anymore anyway. And when you take 30 pills, how are you supposed to eat dinner when you're hungry? You're full on pills. So we look at patients case by case and say, some of these medications, they were great for you 5 years ago. They're just not helping, and they might even be harming you now, and they're riskier to take now. We might add medications. We might get you on new blood pressure regimen and take better care of your fluid overload from your congestive heart failure. So we might actually be doing more, I know it's crazy to think, aggressive medications on hospice care. It happens. What we know is that in particular with congestive heart failure, patients might even live longer in end-stage CHF on hospice. That's because we watch how they're gaining weight and teach them on energy conservation techniques. So in these instances, we're adding things to patients and families to help them achieve whatever they want as quality of life. It might be a wedding across the country. It might be, look, I don't want to leave my home anymore. I just want to be comfortable here. I don't want any physician visits or hospitalizations anymore. Depends on every patient what that looks like. But what it isn't is hospice only does these things for every single patient. It is individualized. So you mentioned infections, and that's such a great example. So sometimes when people come to hospice, they say, well, we didn't come sooner because we heard that if we got a urinary tract infection that we can't take antibiotics if we're on hospice. That is a huge myth. If treatment of a urinary tract infection, when it's medically indicated, right? Because if it's not, that might be a whole different ballgame. But if that's what you want and that's what you think of palliation, it's probably something that you and the hospice are going to do together. At the same time, we might get patients where the family member says, Mom has had 8 urinary tract infections in the last year. We don't want them treated anymore. And we acknowledge that decision and honor that decision too. That's what shared decision making is. And so hospices should be approaching patients and families to first see what's the goal and then how we can work together to achieve that goal. And yes, it can include antibiotics, and it doesn't have to just be morphine. I mean, absolutely. I couldn't say that enough.
I know. We are real doctors.
Yeah, we are real doctors. I said it in a conference I'm teaching at. I just said it this morning. We are real doctors. We still can do real medicine. Absolutely.
And we have to know everything. I was just at that conference in San Diego learning all the updates because I have to translate things to my patients who have been tossed to and fro in the healthcare system, and they want to know if they've done everything. So I'm so glad we talked about that. When you were mentioning the medications and the prescribing, I didn't write this in our notes, but I thought about blood thinners because that is always a topic. Like some people think, oh my gosh, I've been on, Coumadin for 20 years. I need to keep this. And, or my doctor said I have to take this to stay alive. Maybe we could just touch on that for a sec.
Sure, I'd love to. That's such a great example of there are certain things that are indicated or should be used at certain moments in someone's disease pathway, whatever they're walking along. And so thinning the blood, for example, if you have a diagnosis called atrial fibrillation or an abnormal way the heart beats to prevent you from getting a stroke is a wonderful thing for certain people at a certain period of time. But there are risks to thinning your blood using these blood thinners. One of them is that it can cause life-threatening bleeding. And so as real doctors, even on hospice, we have to look at when do those medicines become contraindicated, which means we shouldn't be taking them anymore. And that happens off of hospice. So there's a point where you have to come off of these blood thinners because the risk of bleeding outweighs the risk of trying to keep that stroke from happening, right? So on hospice, when we have our patients who are falling all the time, or maybe they have other blood issues that make them at risk for bleeding anyway, those types of things, it sometimes is the right decision to say we have to stop those medicines because they are worse for you now. They can make things worse. They can make you die sooner. I heard someone say this morning about deprescribing that in hospice, we can't change the mortality or the risk of passing away. But sometimes I can. And so sometimes that includes stopping these medicines that could hasten death. And no, isn't that crazy that we're talking about that in hospice, that we don't want to do that.
Right.
But some of these blood thinners are the best example here, is that they could make that patient pass away sooner. And so it is appropriate for us to talk to you about stopping that medicine at this point. It was the right medicine 2 years ago, but maybe it's not the right thing now. And so that's completely different than you have to stop all your meds. That's an individualized decision with that patient based off of their diagnosis to say, how can we meet your goals? And this medicine is not aligning with those goals.
That's awesome. From a real doctor. All right. So that's fantastic. So let's go on to number 9. We kind of covered this in a recent podcast. So this myth, you must be religious to use the chaplain services on hospice care. The chaplain is one of the members of the interdisciplinary team, a core member we discussed a couple weeks ago. So we know spiritual care or universal emotional support for the patient and family is just something that they provide, along with our social worker. So let's talk about the chaplain care.
Yeah, spiritual support, it is just something I'm so passionate about. We're looking at our patients from a holistic view. And the lens of spirituality doesn't have to have anything to do with a particular religion. It might just be what you believe about life. It may not have to do with Jesus. It may not have to do with Buddha. It may not have to do with anything. It's just your beliefs and support in your belief system. And so that's what they're coming to you with, is a support for your belief system, whatever it might be. And it might be your belief system is, I just believe in being a good person, and that's it. And you still deserve support in your belief system. And so really, when we look at people in terms of relieving suffering, there's so many different components to it. And it's not just about getting right medications. It's about listening, validating human beings and the human experience, meeting them where they're at in challenging times. And so, no, you don't have to have a particular religion to be supported where you're at as a human being in a challenging time. I mean, we are, I think, in the hospice world, I'll just go ahead and say it, the most progressive and supportive team out there for just taking care of human beings. Absolutely. And that is just something that's so incredible to be a part of.
Yeah, it is. It's awesome. And I think it's safe to say every human being deals with, the existential questions and things of that nature. It's just a human experience. And so
Yeah.
I love that. That's what makes it so rewarding, even though it's
Mhm.
so challenging. So, yeah. So, all right, we're at number 10. We could talk all day. Um, so number 10, caregivers don't need breaks. They need to run themselves into the ground, get their blood pressure up, gain all this weight, not sleep to show that they really care. Okay, well, we know that's extreme and I don't want to minimize it. Our wonderful caregivers that, statistically we know provide so much unpaid
Mhm.
labor for our people who are suffering from debilitation, not just hospice patients, but in general. But caregiver fatigue, stress, and burden affects the patient and the whole family unit. You have to take a break. And guess what? There's respite available when you're on hospice care. 5 days can be taken. Why? Why don't you use it? I don't know. Caregivers often don't use it. So let's talk about that as our number 10.
Yeah, I think we're laughing about how hospice gives away vacations. So maybe it's not to that extreme, but there's so much to caregiving. I mean, there's just so much talk about that existential suffering and just the human experience is we're not here just for the patient. We understand that the patient is this part of a bigger picture, the bigger fabric, and that might be their mother that's caring for them or their daughter or their sibling or spouse. And being in that role is hard work. And so, from the hospice perspective, we want to, one, make a plan of care that helps the patient be cared for the best possible and minimize stress, optimize pain management, talk about energy conservation, working in that shared decision making. But part of that is making sure that your caregiving team is also doing okay. So, respite, just this opportunity to have a break where the caregiver is supported. And so it can be done for 5 days continuously. This is done in a facility or a hospice inpatient unit, wherever that hospice is contracting to provide that respite level of care. What we want from those 5 days is to give that caregiver the opportunity to refresh, achieve their own goals. Maybe the wedding isn't for the patient to be able to go cross country, but the spouse can. And so we can love on that hospice patient and take care of them while that caregiver gets a little bit of a chance for a break. And that is so incredible because if you can feed into this caregiver and give them a little bit of support, a little bit of extra sleep, a little bit of time to be a human being and do the things that they need to do, they're going to come back and love on our hospice patient even more because they're also a human being. They need that support. And so this is how we work together with the patient and their caregiving team to give them that little bit of support that hopefully can help them support our patient even better down the road.
Fantastic. Oh, well, there it is. I think there's more we could talk about, but we'll let everybody digest those. I appreciate you, Dr. Templeton, joining me to give this gift of myth busting to the country, to our society, so that we can get improved hospice utilization and dispel those myths that are out there.
Yeah, I love the opportunity. We touched on it. I want hospice patients earlier. The median length of stay is 18 days in this country. And we know President Carter has been on for months now. And it's
Mhm.
such a wonderful example of how we can surround patients in hard times and support them to achieve a quality of life. But if we don't get those patients into the last hours of days, we are missing opportunities to really truly love on people for a much longer period of time. Now, I know it's crazy for people to hear that you want to be on hospice longer, But the number one thing I hear from patients and families is, why didn't I know about this sooner? And so hopefully some of our mythbusters help people to be a little bit less scared about hospice, and maybe call up your local hospice and just ask them questions about what hospice care might look like with that business. And I know you're going to give them resources about how to look up hospices in their area.
Absolutely. We're going to give them Hospice Care Compare. We're going to give them the NHPCO Caring Info. The valuable resource of the week, though, is Dr. Lauren Templeton. So thank you for joining me, and we will be in touch.
Okay, take care.